Well, good evening, everyone, and welcome to the Kingsway Talks. I'm Father Patrick. I'm the rector of All Saints Kingsway Anglican Church here at the corner of Bloor Street and Prince Edward Drive. This is our second installment of the Kingsway Talks, and tonight we're addressing issues of addiction with our special guest, Dr. Anna Holland, from Prince Edward Medical Clinic, just kitty corner to us here at the corner of Bloor and Prince Edward Drive. We're so pleased to be partnering with our friends at the clinic, tackling these issues which affect so many in our neighborhood, in our families, and in our circle of friends. Here at All Saints Kingsway, we are hosting these talks because as a church, we're committed to the well-being of our neighborhood. And we have a joint stake with our friends at Prince Edward Medical in the flourishing of the people of our community. And so I'm so glad you're here tonight, and I hope that this will be worthwhile for you. With that said, I'm going to pass things over to Father Brian, who will give us some housekeeping items, and then he's going to turn things over to Dr. Holland for us. Brian.
Thanks, Patrick. Hi, everyone. We're so glad that you're here tonight. Really thank you for making time to be here. A few housekeeping items for you to be aware of. Please post your questions in the Q&A box at the bottom of your screen. You can do so anonymously if you choose. At the end of Dr. Holland's presentation, Patrick and I will ask your questions to Dr. Holland and give her the opportunity to respond. Also, at the end of the session, there'll be a quick poll that comes up on your screen. We're asking you to give us your feedback. Let us know what you think. And feel free to reach out after today's session if you have further thoughts that you'd like to share with us. Last thing for you to know is that the webinar will be posted on our YouTube page tomorrow. An email will go out to all of you with the link and with a list of resources shared in tonight's presentation. Dr. Holland, thank you so much for being here. Thank you for sharing your expertise with us tonight. We're going to turn things over to you now.
All right, good evening, everyone. Thank you so much for the kind introduction. I'm just going to get my, do a screen share right now. Great. All right, good evening, everyone. Thank you so much for your patience this evening. So my name is Dr. Anna Holland. I'm a family doctor, and I have a specialty in addiction medicine. I practice cradle to grave family medicine care at Prince Edward Medical. And I also provide consultation services for in addiction medicine. And so this evening, I'd like to just give a little bit of a presentation just on substance use disorders, and also especially, I should say, during the pandemic. And I think what we'll do is there's some questions that have come to me before the presentation, and then there's some that I think will be asked during the presentation. And so I think Brian and Patrick will be collecting those. I also just want to say thank you so much for inviting me this evening to give this talk, and recognizing this as an important issue that we need to talk about in our community. So thank you. So we're just going to start with a little disclaimer. So this presentation is not a substitute for medical advice. If you do have a medical concern, please see your doctor. The other thing that I just wanted to acknowledge this evening is that this is really a really big topic, and I'm trying to do it justice in just about 40 minutes for the presentation. And so I'm very mindful that this is a very, very big topic. So this evening, we're going to discuss what is addiction. We're also going to look at a substance use diagnosis and what that means. We're going to talk about risk factors for substance use diagnosis. And then we're specifically going to talk about the pandemic and some of the trends that we're seeing in substance use disorders. And then we're going to be talking a little bit about treatment and then some resources. So what is addiction? So the American Society of Addiction Medicine defines it as a treatable chronic medical disease involving complex interactions among brain circuits, genetics, the environment, and an individual's life experiences. People with addiction use substances or engage in behaviors that become compulsive and often continue despite harmful consequences. Prevention efforts and treatment approaches for addiction are generally as successful as those for other chronic diseases. So I think it's not a perfect definition by any means. However, the main point about this slide is just to say that those who use substances and those who have substance use disorder, particularly, I think there's a move to acknowledge that there is a medical concern, and I think in the past, sometimes substance use issues or disorders were seen as like a failure in character or a willpower problem. And that's just not the case. There's actually science to back it up. And so the importance of making sure that we treat it with empathy and a kind approach and a medical approach as well. So the substance use disorder. So this is from the DSM-5, which is the Diagnostic and Statistical Manual put out by the psychiatrists. So the main thing is that it's actually a group of disorders. There's different severities. So there's mild, moderate, and severe. And so it's seen on a spectrum. So using a substance for larger amounts, unable to cut down, increased time spent accessing the substance, cravings, failure to fulfill major roles, social or interpersonal problems, important social, occupational, or recreational activities are given up, and whether they're physically hazardous. And I should say that shouldn't say alcohol. It was meant to be for any substance, but continued use despite having a persistent or recurrent physical or psychological problem, tolerance, and withdrawal. So a mild substance use disorder is 2 to 3 of these criteria. Moderate is 4 to 5, and then severe is 6 or more. And I think the main thing that you want to think about is whether the substance is having a negative impact on the person's life, and what kind of concerns they're having related to this. And I think the other important thing is to just look at, having tolerance or withdrawal may actually not be enough or isn't enough to say that someone has a substance use disorder. So, and what I mean by this is there's the concept of physical dependence. So for example, if someone is on an opiate medication for pain, if you stopped the medication, they would actually go into some form of withdrawal. It may not be impacting their life negatively. They may not have any of these other symptoms, but they likely would experience withdrawal. And that in itself doesn't mean that they're addicted or that they have a substance use disorder. So some risk factors, we look at genetics. So we actually know that genetics can affect individuals up to 40 to 60%. And I think that number is actually ever changing. It's something that we're recognizing more and more as time goes on, the factors of genetics, but certainly it's not the only factor. And it's also quite complicated genetic inheritance. So it's not one single gene or one single thing that will impact someone's risk, whether they'll inherit or have a problem with a substance in the future. So it's much more complex than just a single gene. And then the other thing that we see is a concurrent having a mental health concern as well. So those who suffer from anxiety or depression or other mental health conditions tend to have a higher risk of substance use disorders, especially if they're untreated. And then we also look at sort of some development factors. So early use, introduction to substances at an early age. There's actually been a correlation with having a risk of a substance use disorder later in life. Also looking at family dynamics can impact it. Trauma, so we now see, or we now know, and there's a lot of evidence that those who've experienced trauma in their life, and so that could be physical trauma, sexual trauma, and any other kinds of trauma, are at higher risk of substance use disorder. And then we know that peers and social factors can influence this as well. And then we also look at things like the drug characteristics. So on how significant or how severe the substance use disorder could be. So for example, onset of action. So how quickly the drug is metabolized and how quickly it goes to your bloodstream can impact how addictive it is. And then also the potency of it as well. So I looked at the pandemic and then also alcohol use, and we've actually seen that 25% of Canadians between the ages of 35 and 54 are drinking more while at home due to the COVID-19 pandemic, or at least we postulate that. And many of the people who've experienced this have talked about there being a lack of regular schedule, stress, and then also boredom impacting it. And this was done in a survey to Canadians. And we've also seen 7 in 10 Canadians who actually report that their alcohol use has stayed about the same. So it's not everyone, and it's not, it's measured, and there's about 2 in 10 people say their consumption is actually increased. So I also wanted to talk a little bit about low-risk drinking guidelines for alcohol. So there's actually been a move to change these, but for now, this is what the Canadian Centre on Substance Use and Addiction says, and this is what the medical experts say. So, and I want to mention that this is a low-risk alcohol drinking guidelines. So it's not no risk, but it is low risk. So to reduce your long-term health risks from drinking alcohol, no more than 10 drinks a week for women, with no more than 2 drinks a day most days. And then for men, it would be maximum 15 drinks a week for men, with no more than 3 drinks a day on most days. And that you should plan non-drinking days every week to avoid developing a habit. And so I just wanted to say, with these max drinks, so 10 and 15 respectively for women and men, it's not that you can save it up and have all of them on one day. It's actually supposed to be maximum 2 per day and maximum 3. And when is 0 the limit? So if you're driving a vehicle or using machinery and tools, taking your medicine or other drugs that interact with alcohol, doing any kind of dangerous physical activity, living with a mental or physical health problem, living with alcohol dependence, pregnant or planning to be pregnant, if you're responsible for the safety of others, and if you need to make important decisions. And this is directly from those low-risk drinking guidelines. And this resource is available at the end of the talk as well. I also just wanted to speak a little bit about the opioid poisoning crisis. And we call it an opioid poisoning crisis, actually, because most of these deaths that are occurring are actually completely accidental. So they're not intentional overdoses. And I think that's really important to realize. And so someone may be using opioids, but they weren't planning on overdosing. It wasn't a suicide or something like that. So the opioid crisis is escalating. It was escalating even before COVID-19 hit. And in Toronto, there have been 293 deaths in 2019 due to opioid overdoses. And in 2020, as of, say, December, there were 299 deaths, although they think that actually the number will be higher once they complete coroner investigations. Again, 95% of these are accidental, and 86% of them involve fentanyl and its analogs. And so we really look at, the toxic drug supply and how this is impacting those who use drugs. And I just wanted to make mention, so in July, we actually lost more Torontonians to opioid overdose than we did to COVID. And I just want to make sure people understand that's not the case now, but just to bring attention to the fact that we are losing, and we are, these are loved ones, and these are people who are dying because of this crisis. And so how has COVID-19 impacted opioids and the opioid crisis? So we know that there's a toxic and unregulated drug supply, and fentanyl or its analogs are involved. And I think some of you may have heard of carfentanil, which is extremely potent. And it's very, very dangerous and risky. And those who may use drugs will not know that there's carfentanil in it or another fentanyl analog that would cause an overdose. Also, during COVID-19 and during the pandemic, we've seen barriers to accessing harm reduction, so safer injection sites and harm reduction workers. There's been, just due to the pandemic and physical distancing and social isolation, we've seen more and more issues with the opioid crisis. And so we're seeing that those who use drugs, physical distancing has been leading to more people using alone. And so there might have been a buddy in the past, or there might have been someone there who could help them if they overdosed. And in this situation, sometimes there isn't. So now I'm just going to switch gears and talk a little bit about living with someone who, or having someone close to you, I should say, who is using a substance. I think what I'm really talking about is those who are struggling with an addiction, struggling with a substance, and it could be a whole array of different things. I think something that's really, really important is to remember to be kind to yourself. Remember that, I think it's really important to realize what you have control over and what you don't have control over. I think it's really important to reach out for support yourself, and also recognizing that there's boundaries and personal boundaries for yourself. And I mentioned counseling. I think even if you're not the one who's struggling with a substance use disorder, I think it could be really helpful having some counseling or some support, someone to talk to. And substance use disorders can often be very isolating. And even those who have a loved one who's struggling, I think it can be very, very isolating for those who are living with them or family members. And I think making sure it's a trusted person that you feel like you can reach out to, but really important that you do reach out. this takes me into just talking about stages of change. And this is a key concept in addiction medicine. So Prochaska, stages of change. And we talk about 5 stages of change. The other thing that I think is really, really important is meeting people where they're at. I really try to do this in my practice. You can imagine if someone's struggling and they're not ready to get help. So I'm going to use the example of quitting smoking, or someone who's smoking cigarettes in my practice, for example. This is a hypothetical situation. So if you have a patient who comes in, they have an issue, say they're coughing, or they have a problem, and you ask them about their smoking, and you talk about the benefits of quitting, and that this may benefit them, and that you really want this for them and you'd like to try to help them. If you go through all these things and before you did all these things, you didn't ask them where they were at, like, is this something that you feel, is this something you want to do right now? Is this something that you feel like is important to you? If we don't do that, then I have the risk of alienating someone, and that's the last thing I want to do. So I actually want to meet them where they're at, and so that they know if they are ready to quit smoking, I'm here for them. But if they're not ready, that's okay, and I'm not going to shame them or shun them or anything like that. That I'm here for them, and when they're ready, I would love to be able to help them quit smoking. So with that being said, I think that can help even those who are living or know someone who's struggling. I think kind of checking in with them and seeing where they're at, or just expressing your concern if you do that, but recognizing they need to be where they're at, and we have to respect those boundaries. So pre-contemplation is the idea that it's not on their radar. They're not thinking about it right now. They have a lot of other things on their plate, and it's not their priority right now. Contemplation is the idea that they're thinking about it. They're maybe just it's come to their attention, or they've thought about it and they've thought, okay, yeah, I would like to quit smoking. I don't have the time, I don't have a date, but I'm thinking about it. Preparation might be something like, for example, I'm planning on quitting next week. I'm gonna pick Wednesday because it's a good day. I'm off. I might have thought about going out and getting some nicotine replacement therapy, or I've told people in my life that I'm preparing for this, or I reached out to my doctor. So that might be a way that someone might prepare. Action would be picking a quit date, following through on your quit date. And then maintenance is, so they've created that action and then maintaining that. So how you can seek treatment, or how individuals who are suffering with a substance use disorder can seek treatment. They can see their family doctor, of course. There's also these really great clinics that we actually have in Ontario called Rapid Access Addiction Medicine Clinic, or RAM clinics. And if you Google them, it actually comes up. The resource is at the end of my presentation. And they're low barrier walk-in services for addiction medicine, and to help those who are struggling. They're actually located throughout Ontario, and there's multiple different locations throughout the GTA. We also obviously want to talk about peer support. Peer support is very, very important. And so we think about, Alcoholics Anonymous or Narcotics Anonymous. Other peer support groups are really, really important. And then we also talk about hotlines. So there's many different substance use hotlines, and there's a couple at the end of my presentation. This list is by no means exhaustive. It's just basically a starting place for people who may be struggling. and just a little bit to talk about treatments. So I think there is a common misconception that there are no medications to help with substance use disorders, and that's simply not true. So there's actually many different medications we can use to help someone who's struggling. So with smoking cessation, so someone who's trying to quit nicotine, we actually have a few very good oral medications that we can give. We have the nicotine replacement therapy. When you look at something like alcohol, we actually have quite a few anti-craving medications that can help someone either quit or even cut down on their drinking. And so important that a doctor is involved in that, or their primary care provider. And then when we look at things like opioids, we actually have really good treatment for it. So we have medications that can be used, opiate substitution therapy, and those are things like buprenorphine or methadone. And so I think it's really important that we acknowledge that and make sure that we're not only looking at non-pharmacological therapy, but also pharmacological therapy. And that's not to dismiss non-pharmacological therapy. I encourage both for my patients. So non-pharmacological therapy could be peer group support, so 12-step programs. There's also therapeutic community, so rehabilitation, cognitive behavioral therapy. MI is motivational interviewing, brief intervention, and harm reduction. So I wanted to talk a little bit about harm reduction. So I think when you look at substance use disorders, sometimes we think about abstinence-based programs. So that means no longer using that substance. And while that's important, and I think that we need to make sure that we offer that and encourage that if we can, but I also think it's important that we make sure that we meet people where they're at. And that can sometimes be harm reduction. So the Canadian Centre on Substance Use and Addiction looks at harm reduction as an evidence-based, client-centered approach that seeks to reduce the health and social harms associated with addiction and substance use without necessarily requiring people who use substances from abstaining or stopping. And so you can think about harm reduction on a spectrum. So I put here the example for opioids or substances or drugs, having a naloxone kit in the home. So making sure that you have that life-saving kit. Naloxone is an antidote for opioid overdose. And it's actually available at any pharmacy. You can get it. It is free. It's not something you need to pay for. And it used to be that there was only injectable available, but now we have nasal spray actually. And so it's not something that you need special training for or anything like that. And having one and knowing how to use one is very important, and the pharmacist can teach you how to do that. The other idea is not to use alone, making sure that there's a sober person present. And then if you're using a new supply, something like doing a test dose, so not using the full amount that you would normally use. For other harm reduction examples would be if someone is smoking marijuana, for example. We know that smoking is actually more harmful than vaping. So if I have a patient who's smoking, and then I will actually, and you know, they're not interested in quitting, and that's not what they want to do. They want to continue to use, but they are open to some strategies to reduce their risk of negative health outcomes. Then I'll recommend switching over to either an edible or vaping. And that's just an example of that. And you can see how you could apply it to many other substances as well. So here are just some resources that I've put together. So the Rapid Access Addiction Medicine Clinics, so the RAM Clinic. There's also obviously Kids Help Phone for kids and youth. There's an addiction, mental health, and problem gambling service. There's also the Ontario Drug and Alcohol Helpline. There's withdrawal management services throughout the city, and that's to get help with going to a detox program. Connects Ontario is also a service that can connect you to resources. There's actually also this National Overdose Response Service, or NORS, and it's actually Canada's first remote safe consumption line that's available 24 hours a day. And this is actually to try to help those who might be at risk of opioid overdose so that they're not using alone, and making sure that there's a safety plan there. And I just wanted to talk a little bit about family and friends who may have someone in their life that's struggling with a substance. So there's Al-Anon, which I believe they've moved many of their meetings online, or most of them, I believe. And that's specifically for family or friends who have a loved one or person in their life that's struggling, and for support for them. And then there's also Families for Addiction Recovery, and they also have services there as well. And then there were a couple questions that were submitted to me prior to the talk. So I think I'll address these two first, and then I can take more questions. So what is the likelihood of alcohol addiction being passed down from one generation to another? So that's a really good question. And I actually don't know the answer to that. And I don't think anyone does, actually. So I think it's, as I said, it's complex. There is for sure a inherited part of it, or like we think that there's some, if you have a family history, there's a risk, but we actually don't know. And I think the person being cognizant of that and aware that that is a history is really important for that individual. Much like if someone has a family history of having a heart attack, we'll never know, you know, whether that person, the child or that person who had the heart attack will have that heart attack, whether it will be passed down. But we can control risk factors. So we can, you know, make sure their blood pressure is good, their cholesterol is good, make sure to check them for diabetes, those sorts of things that can lead to heart disease. And them being aware of that is important, that they have that family history. And I think that sort of speaks to minimizing the risk. So making sure that person's aware, and also trying to mitigate some of those other risk factors that we talked about. So making sure they're, you know, physically and mentally doing well, that there is not that early introduction of substances to them, because we know that that can lead to a higher risk of having a substance use disorder later in life. And then also the risk of trauma. So I think what we know is that we can't do much about our genetics. We are who we are. But I think knowing that and understanding that is really important. And these are just some references, and I believe these will go out to those who attended the talk today. So I think at this point, I'll turn it over to Brian or Patrick. Hello, if you want to ask me some of the questions.
Wonderful. Dr. Holland, thank you so much. We really appreciate your presentation.
Well, thank you.
Questions that have come in for you, so we'll read them to you and give you a chance to respond.
Great.
First question says, hi, Dr. Holland, I had a question regarding the different levels of SUD, mild, moderate, etc. I also consistently see 4 other terms in use: substance abuse, substance use, dependence, and addiction. These 4 categories overlap with the different levels of SUD that you mentioned, or are they different things?
Yeah, a good question. Is there any way for me to see the question, or no? I guess not,
yeah, I'll put it to you in the chat.
Oh, okay. I'm a visual learner as well as auditory, so it's helpful. Thank you.
I get that. Absolutely.
Yeah.
There
So,
you go.
oh, thank you. So substance abuse and substance dependence. I just want to make sure I answer all the questions. And now I've lost the chat. Oh, here we go. Sorry about that. Okay, I found it. Thanks. So yeah, so the substance use disorder is actually from the DSM-5, so Diagnostic Statistical Manual number 5, and the substance abuse and substance dependence were actually from the DSM-4. So it's the previous manual that came out. They sometimes are used interchangeably, you're right. So I think we've moved away from that because we feel like sometimes lines are blurred and it's more of a sort of gray. It's not black or white. And I think so we're moving away from that, but you're absolutely right. So I think like mild would probably be like more like substance abuse, and then dependence, substance dependence would be more in that moderate to severe in the substance use disorder. But those are considered older terms, but you're right, they're still being used. And then, four other terms, substance, yeah. So substance use just is what it sounds like. So using a substance does not necessarily mean that you're addicted to it or that you are that you have a substance use disorder. So someone may recreationally use a substance and actually it may not negatively impact their life. And that could be in many different forms. It doesn't actually matter if it's, as far as I'm concerned, it doesn't really matter if it's an illegal substance or if it's considered like legal in our society. As far as I'm concerned, it doesn't really matter. It's more about, is it problematic for that individual, and looking at their health and well-being. And then in terms of addiction, so addiction is really this sort of broader term that we use in society. So I would never diagnose someone with, for example, an alcohol addiction or something like that. Someone may say that they are addicted to alcohol, or they may say that they're addicted to cocaine or something like that, but it's not a medical term. But it definitely is used, and some people who have a substance use disorder choose to use that term, and that's up to them. Okay.
Thank you, Dr. Holland. Another question came in around parents and recognizing the signs of substance use and changes that are evident in a teenage years at early use.
Yeah, such an important question, and really, I think the answer is there is no one thing. There's not going to be one telltale sign that there's an issue. I think the most important thing, and this is, I want to say that this isn't like a medical thing. I'm actually a parent, so I'm a mom as well. I have young kids though. I don't have teenagers yet, but I think what is so important is making sure that you have open dialogues with your kids, right? Like making sure that you're someone that they can go to and that they trust. And I think, I think if you maintain that, then ideally that would be, it wouldn't be something that they would encounter, but that's definitely not the case. We still see, parents who are doing quote unquote everything right, and they still might have a situation where, their kids experimenting or even having a problematic use. So I guess what I would say is, if someone seems like they're isolating, or if they seem to have sort of some concerns where, socially isolated, which is really hard to gauge actually now that I'm thinking about it during a pandemic. But yeah, social isolation, not interacting, if you see, signs of intoxication, obviously that would be a concern. And then even just a difference, like something that's different for you, like something that's different. Their appetite's off, they're, sleeping more. I can't think of everything that would be the case, but I would say if something seems different, I think it's really important that you talk to your kid And also make sure that they get to talk to a healthcare professional, right? Because even if they don't want to talk to you, they might feel comfortable hopefully talking to their doctor or their family doctor or their pediatrician.
Wonderful. Thanks, Dr. Holland.
Mm-hmm.
A reminder for those of you who are watching, you can still submit questions. We've got a couple more here. What are some of the biggest misconceptions about addiction?
That's a good question. Oh, that's really tough. I think one of the ones that I sort of tackled at the beginning, or at least I hope I tackled, is just the idea that it is not a medical problem and that it's not something that's in the medical sphere, because it definitely is. And it's complicated. It's not only medical. It's not only, you know, one thing, but I think there was an emphasis for a long time that it was more of like a personality problem or a behavior problem or a habit. And so I think that is one misconception. I would say the other misconception that I see a lot is that we don't have good treatments for it. And that's actually simply not true. We do have good treatments. And I'm not only talking about medications, but we do have medications many times, but also that we don't have insight into therapies or different groups, because we know that actually peer support works. There's actually been studies. We actually know that counseling works. We know that brief intervention works, and we know that medications do work. So yeah, so I would say like the non-medicalizing it early in many years ago, I would say, and then also not that we don't have good treatments, because we do.
Thank you, Dr. Holland. In the interest of, as you said, meeting people where they are there safe injection sites in this area of the city?
Are there safe injection sites currently in this area of the city? So I don't believe so, not in Etobicoke, as far as I know. The one that has the biggest net, or like the biggest one we have in the city, is called The Works, and it's downtown near Sherbourne on Victoria Street, I believe. And if you actually Google The Works, they actually have satellite locations. I believe there's one in Parkdale. I don't know the exact address, but I believe, I could be wrong, I believe that's the closest one we have. Yeah.
Thank you.
Another question for you here about the impact of COVID-19 on harm reduction treatment centers, particularly opioid. Sorry.
Okay.
What are some of the barriers, and what have public health units recommended for providing this service while preventing and controlling infection by COVID-19?
Yeah, so good question. I think in terms of opioid agonist treatment, so opioid agonist treatments would be things like buprenorphine and methadone. And so those continue to be up and running. I see patients in that sphere. And I think like a big part of opioid agonist therapy is building trust over time, and also developing a system where patients gain carries over time, which means that they're at the beginning of their treatment, they're often supervised at the pharmacy. So taking their medication at the pharmacy each day. And we've actually, as addiction physicians, we've developed protocols where we're actually getting patients to take more doses home because of COVID-19, and trying to reduce the amount of time individuals need to go out. Obviously, we have to weigh the risk in terms of, especially with methadone, there's a higher risk of overdose with that particular medication if someone's not taking it as prescribed. But that would be one change. And then I think, as I mentioned in the talk, some of the barriers, like the works was closed for about a month at the beginning of the pandemic. So that was like almost a year ago. But that's like unheard of. Like that's unheard of that there would be a harm reduction facility closed. And that was because of physical distancing. And we didn't know what was going on with the pandemic. And we didn't understand, we didn't know enough about COVID-19. And so my understanding is that the safer injection sites are up and running now. They obviously have fewer people in them. And, you know, the harm reduction workers, everyone's wearing masks and all that sort of stuff. And that's really what I've seen, is that they've used personal protective equipment. And then the people who use these facilities are asked to wear masks, and so they've made those changes.
Thank you, Dr. Holland. Two questions came in. One around your talking about readiness and about the old notion of an intervention. And someone else asked, what is motivation intervention, MI? And I'm wondering if they're interrelated, if these are related questions or if they're not.
Sorry, can you ask I don't think they're related.
Question has you talked about being ready, the notion of readiness.
Yeah.
About the old notion of intervention, of an intervention.
Oh, like an intervention, like okay. Yeah, I think like an intervention, I guess the idea of an intervention is sort of expressing your concern, like for a loved one or whatever. I think, you know, I've seen on, like, you know, popular media or whatever, like interventions, and it's like a big group of people and like kind of, I don't know, like singling that person out, and it's like a whole group of people, everyone who like knows them in their life and is like, you know, we're really concerned about your whatever, and you know, you need to stop or whatever, and we, you know, you need to do this, and you know, we'll help you. And it either goes well or it goes really, really badly. I think that I don't recommend doing that. I think there's a big risk with that. I think if you talk about the idea of just sort of talking to someone and saying like, hey, I'm really concerned about you, or I've noticed this in a non-judgmental way, I think that would go over better. Most humans do not like being attacked. And I think that even if everyone has the best of intentions and it's all because, you know, we love them and we support them and we want to help them, I think if you're struggling yourself, I think self-esteem is a huge issue. And I think if people already feel badly about themselves or are not at that point, it could just really derail the situation. So I think if you do like the intervention where it's like the group of people, maybe not the best thing to put someone on the spot, but I think the like soft check-in, like, hey, I'm concerned. How can I help you? Is there anything I can do to help you, or something like that? I think that might be better received. And then motivational interviewing is the second one. So MI. So the idea is getting an idea of where people are at. And a big concept is rolling with resistance. So that's the idea that I was talking about, where you check in with someone and find out what they're thinking and where they're at, instead of us going in saying like, okay, you need to quit smoking, you need to do this, you need to do that. And, you know, finding out what are their barriers, or where do they even want to do it? And some questions that I use in my practice is, you know, on a scale of 1 to 10, how important is it for you to quit smoking? And if they say 10 out of 10, I'm like, okay, great. Like, let's figure that out and try it. And if they say, you know, 6 or 7, I say, okay, so, you know, you said 6 or 7, why not 8 or 9? Like, what made you say 6 or 7, and why not closer to 10? And then I'll also go through the same thing with confidence, because if it's important to them and then they want to, for example, quit smoking, I want to know how confident are they So if they say to me, oh, it's a 5 out of 10, and I'll say, okay, how could we get you to 7 out of 10? How could we get you to 8 out of 10 in terms of confidence that you can quit smoking? And that's the idea.
Wonderful. Thank you so much. Just one more question here for you.
Yeah.
Sorry about that. In your opinion, what's the #1 challenge or barrier to addressing Canada's opioid crisis?
Oh, that's oh my goodness, that's a big one. Oh goodness. That, you know, like, do you have like 5 hours? I think so. Okay, so I'll get a little political here. I think, but not too political, don't worry. I really, I think it's about stigma, honestly. I really think it's about stigma. I think it's about the way our society views individuals who use drugs, and that it's some kind of moral failing, or that they're, you know, a bad person, or they got wrapped up into the wrong crowd, or that they, you know, made the wrong decision or whatever. And I think that I honestly think that's the first step, is if we as a society decided that we wanted to value those lives as much as we wanted to value other lives. And I think that would, because we know that the people who are dying from the opiate crisis are actually a lot of young people in like I don't know if you want to say the prime of their lives, but like they're, you know, like 30s, 40s, like they're young people, and it's unintentional. And so I think I think we also should be involving people who use drugs in the solutions, because, and that's kind of like, you know, a little radical, but it's not so radical. Like, it kind of makes sense to how do we help you? How do we make this better? How do we make things safer? Yeah. And then I guess the other thing I would say is the fact that opioids are illegal, right? So we have a toxic, unregulated supply. And so I think there's so many things. I literally could talk about this for like, I don't want to say an hour. I could talk about it for like days. But I do think it's about stigma. That's my personal opinion. I just want to be very clear. Like, yeah. Mm-hmm.
Wonderful. Dr. Holland, we are so glad you could be here with us tonight. We really appreciate you taking time to share with us. Thank you for the resources. We'll get those slides from you and share them in the email tomorrow. To all of you that joined us tonight, thank you so much for being here. I hope this has been helpful for you. If you don't mind just taking a moment, there's a poll going to come up on your screen, and if you would just answer those questions quickly, we really appreciate your feedback. Once you've had a chance to give us your feedback, you can feel free to sign off and look for an email to come from us tomorrow with the link for the video and the resources. Have a good night, everybody. Thank you.